Just to review the significant anatomy that we talked about on Monday and then again today, typically you have two kidneys, two ureters, one urinary bladder, and one urethra. And sometimes you have uh, some variations as well. Sometimes you'll have where'd I go? Sometimes you'll see a patient with one large kidney and one small kidney. The large kidney is hypertrophied, not hypo, but hypertrophied to compensate for the smaller kidney. If you have a kidney that's out of place, it's what you call an ectopic kidney. If you have a transplant, the transplant is typically going to be positioned in the pelvis rather than in the kidney's normal position. So sometimes you can also have, instead of two ureters, what we call dual collecting systems. And what a dual collecting system is a patient has two renal pelvis. This is renal pelvis here. So the patient may have a renal pelvis comes off in two different places. And finding a patient that has a dual collecting system is what you call an incidental finding. It's generally not associated with whatever kind of problem the patient's having at the time, unless those two ureters stay separated all the way down into the bladder. And what happens in some cases is the two separate insertions of two separate ureters occur, and only one of those will have a good sphincter control to seal the ureter from the bladder. And what happens whenever you don't have a good seal is that whenever the patient urinates, you get reflux from the bladder back up into the kidney. And that would come with it an association with increased kidney infections. So the dual collecting system is typically an incidental finding, but repeated infections, kidney infections, could be a symptom that the patient has a dual collecting system. So shaped like a kidney bean. The convex portion is on the lateral side, concave portion is on the medial side, and the concave portion is where the hilum is, and the hilum is where the blood flow comes in and out, and the ureter comes out as well. So each one is approximately, well, they're similar in size, not exactly the same in size, but they're similar in size, but there are some differences. First off, the left kidney is going to be positioned higher because the right kidney is up under the liver, which pushes everything on the right-hand side down. But the left kidney is also a little bit longer, and the significance of that is that sometimes whenever you position, you may have to position a little bit higher in order to make sure that you get the upper pole of the kidney on the left-hand side. We talked about the kidney stones and when kidney stones become a problem and where it is that kidney stones in a lot of cases will stop in their travel from the kidney down to the bladder. And we said that the upper portion of the ureter, where the renal pelvis tapers down into the ureter, that's a good place for them. Where it comes across the pelvis is a good place for them. Today we mentioned at the bottom of the bladder, or I'm sorry, the bottom of the ureter right before the bladder. Sometimes they'll lodge there. Sometimes you'll have a patient who has a staghorn kidney stone, and a staghorn kidney stone is a stone that's so big that it completely fills up the entire collecting system. So it may start here and completely outline every major and minor calyx, and it kind of looks like a moose's horn, an antler. And that's why you call it a staghorn, because it looks like a large deer type animal, like a moose, their horn. I'm not going to talk about the microscopic aspects a whole lot. The nephron is where you've got the functional unit of the kidney. You can get into the renal corpuscle and study that if you want to, and the Bowman's capsule and glomerular capsule and all that if you want to. But just know that the nephron is the functional portion of the kidney where the urine is made and secreted into the collecting system. So you've got the afferent vesicle, you've got the efferent vesicle, all that. The kidneys, of course, drain into the renal pelvis, and the renal pelvis drains into the ureter, and the ureters are roughly 10 to 12 inches long, depending on a lot of things, including where they are found inside of the patient's body at birth, really. An ectopic kidney is probably going to have a shorter ureter than a kidney that is in its normal place, so to speak. And the whole purpose for the ureter is just to transport the urine from the kidney down into the bladder. The bladder is just a sac. It's a collapsible sac, and it, for the most part, you've got this almost like a stomach appearance to it, where it'll collapse down, and you've got these folds where it is elastic, so they can stretch out and contract and hold, obviously, more urine, except for this one little area right back here, and that is where everything attaches. You got the ureter, or the ureters that attach on the posterior inferior side, and then you've got the urethra that attaches, and this entire area is less, I guess, less expandable than the rest of the bladder. And the significance of that is that whenever the bladder fills up and it starts pulling on this area, that's what tells you you've got to go. The rest of the bladder continues to stretch. Obviously, there's a critical point where it's not going to stretch anymore, but as it stretches, it starts to pull on this little smooth area right here, this trigone, and that alerts you that you need to empty your bladder. You've got the urethral orifice here, and then that's what conveys the urine to the outside of the body. The prostate is not a portion of the urinary system, but because of its location you'll see on KUBs sometimes. If the patient has a full bladder and you can visualize a bladder, you may see a little bump on the bottom side, and what you're seeing there is actually the prostate. And then the urethra passes through the prostate, and so it's worth mentioning here. Because of its location on the bottom side, and with the urethra passing through it, sometimes a patient with prostate issues will have an increased urgency, so that leads to an increased frequency. So Trina probably talked about contrast media last semester. We're going to talk about, we'll mention that as well, but we're going to talk about the studies mainly. We talked about the adverse reactions. You've got mild, intermediate, and severe, and placebo reactions, and we talked about those on Monday. Preparation is pretty much the same as other contrast studies of the abdomen, and that is certainly NPO after midnight, but some hospitals may require cleansing enemas or even laxatives, things like that. Patient preparation, for the most part, is go ahead and put them in a gown. If you're going to be taking multiple KUBs on a patient, there's a pretty good chance that their pants are going to work. If you just have them lower their pants, there's a pretty good chance their pants are going to work their way up into the image, so that one of your images will wind up with a zipper or a snap or a button in it. So we talked about the difference between retrograde and antegrade filling. Retrograde is going against the flow, as opposed to antegrade is going with the flow. So what we're hoping to see in each one of these, if it's an antegrade study, we're looking for function. So IVP is a functional test. Excuse me. It's a functional test because we're going to get to visualize how the kidney works. We're going to see the contrast collect inside of the kidney, and then be able to visualize its travel from the kidney down into the bladder. As opposed to a retrograde study, in most cases with a retrograde study, we're looking for specific pathologies, be it stones or maybe like the cystocele that we were talking about before. Maybe we're looking for a ruptured bladder like what we talked about today, or maybe we're looking for reflux, and we'll talk about that in the most common studies for reflux here in a bit. So in selection of contrast, I don't think that I've worked in a hospital that routinely used ionic media. So everybody uses non-ionic contrast media. The significance of that is that the incidence of reaction are significantly lower with non-ionic media. Now, we talk about the different types of reactions so that you can watch for them, but maybe I was just fortunate in my career. I never saw a single positive reaction to contrast media. When we inject in the contrast into the patient, if we're doing an antegrade study, the chances of reaction are much greater than for retrograde studies. So you may see some ionic contrast for retrograde studies, but for antegrade studies, for the most part, you're going to see non-ionic. So IsoView would be a name brand for non-ionic. Renographin would be a name brand for ionic. So we talked about the what the textbook referred to as mild. Mild would be just the feeling of warmth, the flushed feeling, the rapid heartbeat. They call hives, mild, short duration type interaction. If you see a patient truly breaking out in hives, you should be on high alert. You probably need to go ahead and have somebody available, pass that information on, and see if they want to go ahead and give the patient some Benadryl or something like that. I would go ahead and pass on any kind of reaction. If the patient truly gets sick, I would pass that on. Edema of the respiratory mucous membranes. Now you're starting to get into some degree of respiratory distress. Somebody needs to be in the room taking care of the patient at this point. And severe reactions, somebody should already been in the room, probably administering epinephrine, certainly some Benadryl, things like that. The exam comes to a stop at that point. So we talked about preparation, maybe some enemas, that sort of thing. The laxative the night before may need to be a lower fiber so the patient's not full of gas whenever they get there. If they do take a laxative, preferably one that doesn't cause the patient to have a lot of gas in their bowel on the day of the procedure. If your patient is diabetic, you need to prioritize the diabetic patient to have their exam earlier in the day than later in the day. Also, if they're diabetic, you need to quiz them on what kind of diabetic medications they're taking and pass that along to the radiologist. Same thing with multiple myeloma. If they have high BUN and creatinine levels, those need to be passed on to the radiologist as well. We talked about that on Monday. If your department protocol and your radiologist preference is to have specific markers on the image, time interval markers, make sure that you have those available, laid out, and set in an order so that you can just kind of follow the order. Take one, put it on the image, make the exposure, take that marker and put it away so that you don't make a mistake and use it again. You might also have one for PA projection and one for upright, just in case The radiologist asks for upright images, or they have you turn the patient over and shoot some of the images PA. The purpose for turning the patient over is that it provides a certain degree of compression that so that if the patient needs some minimal compression, or if you have a pregnant patient that you want to save dose to the baby, to the fetus, you can shoot them PA, and you can identify those as PA as opposed to being AP. Make sure you have your emergency cart, make sure it's stocked with the medication that you might need in case of an emergency, the epinephrine, the Benadryl, and make sure that you've got the supplies. If you're not doing venipuncture, just make sure that you've got the supplies to inject into the catheter. So you need to make sure that you can control motion. One of the worst studies I ever got on an IVP was a patient who she was a little bit of a hypochondriac to start with, and then the ER doctor over-medicated her, and that made her really high. She was basically high on pain medication, and that made her paranoid, which fed into her hypochondriac nature, and she was just moving all over the place, and it was a miserable study. So just to make sure that you get a good study, make sure that the patient can cooperate. Good instructions are mainly what you're going to use to control motion for an IVP. Respiration, according to the textbook, each one of your images should be shot at the end of expiration. But a lot of our radiologists want you to shoot on inspiration. So that's one of those things that's the test questions are going to ask you what phase of respiration should you make the exposure, and the answer is going to be expiration. But if your hospital protocol and your doctor's preference is to shoot on inspiration, just follow the protocol. The test question is going to be expiration. Before we get into the procedure itself, you're always going to shoot a scout. So a scout would just be, for an IVP, would just be your KUB. Okay, so dress the patient, go ahead and take the pants off, take the shirt off, give them a gown to put on, and then shoot a KUB on whichever phase of respiration that your radiologist prefers. Radiation protection is going to be very difficult, especially on women. On men, you can try, but just make sure that any kind of shadow or contact shield that you use doesn't get in the way of the exam. Really, fundamentally, your radiation protection should primarily be your collimation and proper positioning. So where this says contrast is the same as for abdominal radiographs. That's radiographic contrast. That's not contrast media. So what we should be able to visualize are the kidneys, the psoas muscles, and the lower border of the liver. Probably of the three, that's the hardest thing to see. So patient cooperation, good instructions are certainly the main means to control motion, but secondarily to that would be to select a technical factor, MA and time combination that would give you the shortest exposure. We talked about the use of compression and why we use compression. That would be just to slow the flow of urine from the kidneys into the bladder. But the times that we don't want to use compression would be if the patient has something blocking that you could do more damage to the patient. And most commonly that's going to be kidney stones. But where you would put those would be right over the ASIS, maybe slightly more towards midline for the ASIS. And you can check with your clinical site and see what the compression device looks like. So kidney stones primarily, some sort of abdominal mass, maybe aortic aneurysm you don't want to poke around on. Certainly if the patient's got a colostomy bag, you don't want to put compression over the top of that. If they got a suprapubic catheter, that may be from a ruptured bladder because they were in a trauma, you don't want to mash on that either. The rest of those slides we already talked about. I added this slide this morning So it's not in the PowerPoints that are posted in Canvas. It's just word parts to help you to understand what it is that we're going to be looking at and what the words mean. Nephro, anytime you see nephro, that means kidney. Pyelo means renal pelvis. Uretero is just the ureter. Cysto is sac, and in this case, it's going to be the urinary bladder. Urethro would refer to the urethra, and then the suffixes would be gram, scopi, and tomo would be actually a prefix. All right, so let's go back up to this. So a nephrogram would be a radiologic procedure of the kidneys. A pyelogram would be a radiologic procedure to image specifically the renal pelvis, and so on. Scopi is a suffix that just means using a scope for direct observation. So when we have nephroscopy, then what that is they put a scope all the way up through the patient's urethra, into the bladder, and then up into the ureter. So all the way up into the kidney, so that they can see all the way up into the kidney, and so forth. Tomo is the use of motion to blur superimposed structures. And that motion could be from patient motion or X-ray tube motion. So that seems kind of counterintuitive that we would use motion to see something better. But think back to last semester in breathing techniques. That is a form of what we call autotomo. So you're having the patient breathe, and let's say on a lateral T-spine, you're having the patient breathe. So the T-spine doesn't move a whole lot, but the lung markings do. So the lung markings blur much more than what the T-spine does. You can see the T-spine a little bit better. So that'd be an example of an autotomo. Here where we use tomo is if we need to do specific cuts of the kidneys. What happens is the X-ray tube moves in one direction while the image receptor moves in the opposite direction at the same speed, but they stay perfectly lined up. And what happens there is that we're using the movement of the X-ray tube and the image receptor in opposite directions at the same speed to blur out structures furthest away from the point right dead square in the middle of that pivot. So that's what you call a fulcrum point, where the like a seesaw pivots. That is what you call a fulcrum point. So thinking about the seesaw and the plank across the seesaw, what moves the most whenever you go up and down on a seesaw? Is it that pivot point, or is it whatever's furthest away from that pivot point, where you're sitting and your friend are sitting? That should be pretty obvious. It's the distal ends of it. So whatever is experiences the most movement in relationship to that pivot point is going to be most blurred. So what we try to do is put the kidneys right at the pivot point. The kidneys stay relatively sharp while the rest of the anatomy gets blurred out. So sometimes we'll do tomography of the kidneys whenever we're doing IVP. Procedures that we're going to talk about are primarily the IVP and the different options for the IVP, the retrograde urography, which we talked a little bit about in class this morning, cystography that we talked a little bit about, and cystourethropy, which usually incorporates voiding to look for that reflux, most of the time on little kids, and more specifically on little girls in most cases. We'll also talk about some surgery procedures where we do the retrourography all the way up into the renal pelvis sometimes. So intravenous urography has got a lot of different names. Antegrade urography because you're going with the flow. It's excretory urography because you're excreting the urine and you're going to make exposures all the way through post-void. intravenous pylorography is most common name for it. And what it shows is the structures and the function of the kidneys. So all of these exams that we're talking about, all these back up here, are non-functional with the exception of the intravenous, the antegrade urography. So what generally we're doing that for is to look for kidney stones or any other kind of obstruction, but primarily it's going to be kidney stones. But there may be some congenital issues there. We may be looking for what might be causing specific indicators in urinalysis tests or possible recurring kidney infections, urinary tract infections, things like that. So primarily stones, but it could be for other things. Risk factors, certainly contrast reaction, but if the patient has asthma, they could have an increased likelihood of having an asthmatic attack whenever we inject the contrast. One of the scariest IVPs, and I think I communicated this last semester whenever we were going through KUBs, and I know you had a lot going on at the time, so you might not remember it, but one of the scariest things I ever had was a patient was presented for an IVP, and the reason for the IVP was they thought he might have had a kidney stone because he had this nagging low back pain that would have suggested that it be in the area of the kidneys. So we shot the scout on the patient, and the patient had a massive abdominal aortic aneurysm, and it was poorly calcified, and the calcium inside the aneurysm actually helps to strengthen the bulging wall so that the patient doesn't, the aneurysm doesn't rupture. This thing was huge, and it had almost no calcium in it, which made it very dangerous. If we had injected him with 100 cc's of contrast in a bolus, it could have elevated his blood pressure, and he could have opened that aneurysm on the spot. So cardiovascular disease is a possible risk factor. You certainly don't want to pop somebody's AAA if they have indications that they've got decreased kidney function. Sickle cell disease, diabetes, multiple myeloma are all high risk for this particular exam. And with those high risks, they may elect to do a CT with minimal contrast or no contrast at all, rather than a bolus injection IVP. Also, with high blood pressure, sometimes we don't want to bolus the patient. Instead, we'll do what we call a drip infusion IVP, or a hypertensive IVP. So we'll talk about that here in a minute. Most commonly, what we're going to do for an IVP, and I'm just going to kind of shorten this, is we're going to do KUB after KUB, kind of like a small bowel, but they're going to be in shorter increments. So what we're going to do is draw up the contrast. We're assuming that we already have venous access. So we're going to draw up the contrast, make sure that you check the contrast, make sure you're giving them the proper contrast for injectable contrast, iodinated contrast. But also check the expiration date. Sometimes if a bottle of contrast sits in the cabinet and it kind of keeps getting pushed back to the back of the cabinet, then it may be out of date, it may be expired. And if the patient reacts to it, then that's just going to be open and shut case in most cases for if they have a lawsuit, if they press a lawsuit. So what we're going to do is get the patient into the room. If the patient has to use the restroom, if they feel any kind of urgency, or if they feel like they've got anything in their bladder, go ahead and have them empty their bladder. Shoot the scout, and then dress the patient, and then we're going to inject 100 cc's of contrast. Or if it's a smaller patient or a pediatric patient, the radiologist is probably going to tell you how much that he wants you to inject. So after the scout, what we're going to do is inject the specific amount of contrast that we should inject for that particular patient, and then we're going to shoot an image right after that. So different hospitals call that different things. Some will call it a 0 minute, some will call it an immediate film, whatever. It's just as soon as you get that bolus into the patient, go ahead and have everything set up so that you can walk around and you can make your exposure. None of the contrast is going to be out of the kidneys yet. You're not going to have any in the renal pelvis, so there's really no reason to shoot an entire KUB. Instead, what you would do is you would center at the angle of the ribs or the bend of the elbow, or put the bottom of the image receptor at the top of the crest, and make sure that you get the top of the left pole. So if your patient's got an uncommonly high waist, then you might want to center a little bit higher than that. But those are your guidelines: is the angle of the ribs, bend of the elbow, bottom of the image receptor at the top of the crest. All we're looking for is kidneys at this point. After that immediate image, we're going to shoot one every 5 minutes. So you're going to shoot a 5-minute image. Most of the contrast is still going to be in the kidneys. So you want to make sure that you get the top of the kidneys and as much of the ureter as possible. So in this case, for the 5-minute image, what you might want to do is position more like you would for an AP of the L spine. So find your crest and use 14 by 17 collimated field and put the image receptor just above the crest, maybe 3 fingers width above the crest, to make sure you get the top of the kidneys. Now, the reason a lot of our radiologists want us to shoot on inhalation is because the computer algorithm, in all honesty, is what controls your contrast now. And that little bit of increased scatter radiation that you're going to get by shooting on inhalation is not going to change your image all that much. So a lot of your radiologists will just have you shoot on inhalation so that they can see from the top of the kidneys all the way down to the bladder on every image. If that's the protocol, then go for it. But again, the test question is going to be specific to what phase? Exhalation. So in that context, what you would do on the 5-minute is position slightly higher than what you would for a regular KUB. Every image after that, you're going to center as if you're shooting a KUB. So you'd center at the crest. So 5-minute is like a high KUB. 10-minute is going to be just a regular KUB. And depending on your doctor, depending on your hospital protocol, you might shoot 15-minute KUB with 15-minute obliques. And the obliques are going to be a 30-degree oblique, and we talked about that in class this morning so that we can see a better frontal and more of a lateral view of the kidney, and also see the ureter insertion down in the bladder. So what we're going to see on the upside, the kidneys can be more flattened out. On the downside, it's going to be more lateral. And then we're going to see the ureter insertion on the elevated side at the distal end down at the bladder. So 0-minute, 5-minute, 10-minute, and maybe 10-minute with obliques, and maybe 15-minute with obliques. And then if everything is flowing well and we don't see any kind of evidence of obstruction, you'll take those images, you'll take them back to the radiologist. Radiologist will look at them and say whether or not we need to continue, or if you can have the patient get up and void their bladder. After they void their bladder, you're going to bring them back and shoot a post-void. So the post-void may be shot upright, or it may be with the patient laying down. Most of your doctors are going to have just a regular KUB, but some of your doctors will have a protocol asking you to shoot an upright post-void. And if everything is good at that point, then you show everything to the radiologist, and the radiologist will tell you to release the patient. If you have a patient who has some sort of blockage, kidney stone, mass, something that's causing the blockage, then you might have to drag that out a little bit longer. It may be 0, 5, 10, 15, 30, and so forth. So So after the procedure, what you're going to have, your post or your discharge instructions for the patient is to drink extra fluids to help flush that through. They probably came in somewhat dehydrated, so that'll help to hydrate them as well. One thing I forgot to mention when we were going through the GI studies is that with those contrast medias as well, you want to have the patient drink a lot of fluid. We have a tendency to stress that on barium work, and we should, because if the barium sits inside of the patient's body in the colon, the job of the colon is to pull moisture out to help to regulate homeostasis. The patient came in dehydrated, and we pumped them full of this basically cement in a water mixture. The colon may pull some of that water out, and the patient's left with hardened barium inside the colon. That's a bad situation. So you want to have the patient drink a lot of fluids after any kind of barium study. But what sometimes we neglect to mention is that whenever we do iodinated studies of the GI system, we have the contrast has a laxative effect. So with laxative effect, what you've got is you've got a patient who's already somewhat dehydrated, then we put a laxative inside of them, and their body dumps water into the colon to flush all that out. So the patient leaves more dehydrated than what they were when they came in. And for most young people, that's not as big of a deal. You're going to drink whatever, and you're going to bring your water levels up. But your older patients are the ones who are most likely to have the GI studies done. And if you send them out really dehydrated, it could be a bad result for them. So regardless of, went all that way to say, regardless of what kind of contrast studies we're doing, be it intravenous or GI studies, you really need to instruct the patient to drink a lot of fluids after they leave. So we talked about all that already, so we're going to skip through it. Hypertensive IVP is essentially the same as a regular IVP, but what we're going to do is maybe not bolus the patient, but maybe have some sort of drip infusion. And our studies are going to be more rapid, so we're going to shoot one every minute for the first 5 minutes, and after that, we're just going to shoot regular IVP films. So hypertensive IVP may be a bolus, it may be a drip infusion. Drip infusion just essentially means that you're going to put the contrast, maybe spike the bottle, the container of the contrast with the IV tubing, and let it just drip into the patient. And that's what that is. He's just describing positioning for KUBs. You know what that looks like. So I'm not going to waste your time with that. So here we've got, it's probably a 10-minute image. You can see contrast all the way down into the patient's bladder. So you've got good filling. If you've got a patient who's got a kidney stone, what you'll see is you can see the outline of this kidney, and what you'll see in a lot of cases is the ureter is not, you can kind of see how fine they are, how narrow they are. They should be like that. But what you'll see is great big fat puffy ureters, and maybe the nephrogram, the contrast is still out in the parenchyma of the kidney. The kidney just looks huge, and you've got a lot of contrast out here instead of in the collecting system. Obliques, we talked about that. About 30-degree obliques. We talked about what it'd show. And so here is an oblique. So you see one kidney here, more of a lateral view there. That would be an RPO. Down here, these things that you're seeing, that is actually evidence of compression. So what these are these great big, not that big, but they're these inflatable pads that you put onto the patient's lower abdomen, right at the level of the ASIS, and inflate those. So as you inflate those, it pushes the soft tissue back into the ureter, and it kind of compresses the ureter. So again, obviously, if a patient has a kidney stone suspected to be right over where the ureter comes across the pelvis, you don't want to put these on the patient. Lateral is a possibility. I don't think I've ever shot a lateral of the urinary system in my entire career, but textbook says that it could happen, so I suppose it could happen. Never shot a dorsal decubitus for urinary system either, but there you have it. So we're just going to skip through it. Common pathologies: hydronephrosis is the water on the kidney because of a stoppage in most cases. Ureterocele, we talked about that before. Ureterocele is where we've got at least a partial prolapse of the ureter into the bladder. Urolithiasis would just be kidney stones, and they could be in the kidney, they could be in the bladder, they could be in the ureter on their way to the bladder. So some patients will develop bladder stones, and some of the stones that are in the bladder just come from the kidney. So you got regular kidney stones and you got staghorn kidney stones. Nephroptosis, you got double collecting system, cystocele, and that is your prolapse of the bladder basically into the urethra. And horseshoe kidney is something I forgot to mention. So horseshoe kidney is where the lower poles of the kidneys connect to each other. So you've essentially got one big kidney connected at the bottom. And the significance of a horseshoe kidney is that it will, because of its position here, is horseshoe kidney. You see the way the lower poles are connected, and the way the renal pelvis comes off. Kidney stones that form inside of the kidney have to kind of climb a hill in order to get out of the kidney. And so as a result, patients with horseshoe kidney have a higher incidence of kidney stones than patients who have just a single, have two separate kidneys. Dual collecting system here. So we got an ectopic kidney, nephroptosis, just a kidney out of place. We got bladder stones. We got staghorn kidney stones. That looks like contrast, but it's not. It looks like this patient's got some pretty severe scoliosis to go with it. Ureterocele, they call it the cobra head sign, but that's what you're looking at there is prolapse. And then you've got hydronephrosis, and it's just too much water, usually because of some sort of obstruction, mechanical obstruction. And finally, we've got a very large, enlarged prostate. Trina's going to go through tomography in your second year. I posted a couple of videos to kind of show you what tomography looks like and what it is that it does in this same module, in this same section. So you can take a look at those and kind of hopefully be able to wrap your mind around what it is we're trying to accomplish with tomography. So, you consider what CT is, computed tomography, and that's the use of motion to remove superimposition. Tomography is just basically very first generation, very primitive CT without the C. So just regular tomography. So retrograde urography can take a lot of different forms. So retrograde urography just means that we're going against the flow and we're looking for something. So retrograde pylography would be we're looking all the way up into the renal pelvis. Retrograde nephrography would be all the way up into the kidney. Since we're going against the flow, these aren't functional exams. They're just looking for something specific, usually a kidney stone. And what we do these for in a lot of cases is to find a kidney stone, and a lot of these are done in surgery. Find the kidney stone, focus on the kidney stone, and they've got a couple of different, well, really three different ways to remove kidney stones. One is with a basket like what we talked about when we were talking about ERCPs on Monday. That's one. One is using lasers to break up the kidney stone. So what they'll do is they'll put a scope all the way up into the ureter and put a wire right up against the kidney stone, and then run laser through the wire and break up the kidney stone. So that's what they call laser lithotripsy. Lithotripsy just means breaking up of a stone, a rock. And the other would be with what they call SWAL. That's electronic shock wave lithotripsy. And with that, what they do is they use sound waves to break it up. So they put the patient either on a pad that is, it's sealed water under the patient, but it's conductive so that sound waves can come up through that pad. Or in some cases, they put the patient completely into some sort of water bath. And they create a very intense sound, sharp sound, and they focus that sound directly on the kidney stone and they break it up. So if you ever go to surgery and they say we're doing lithotripsy today, that means one of two things: either laser lithotripsy or it could be the S-wall. And it's worth watching once. Certainly if you're in surgery, you don't want to say, oh, I don't want to go do that. I've already seen that before. No. If somebody says, come on, we're going to go do an S-wall, then you go and you do an S-wall with them. But it's pretty mundane. The shock waves work off of, I think it's the P wave of the heart, of the sine wave, cardiac sine wave. So they can only energize based on that particular portion of the sine wave. If it's anywhere else, it could put the patient in cardiac arrest. So if the patient has a heart rate of 60 beats per minute, then what all they can do is give the patient 60 blasts per minute. And it may take hundreds of shock waves to break up a kidney stone. So what the anesthesiologist will do in a lot of cases is give the patient some atropine to speed up their heart rate and try to get it done a whole lot quicker. At the time that I was working in surgery, the machine that we would use could only go up to 100 beats or shock waves per minute. So a really good radiologist will get you up to 95 to 99 beats per minute and keep the patient there. The problem is if we went over to even 101 beats per minute, what that did was it shut down the lithotripsy to one pulse per minute until the heart rate came back down. So because it's, after you get the patient positioned, it's just sound after sound, and it's just a crack, 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 crack for 30, 45 minutes. It's kind of cool to see the first time, and then after that it's not all that cool anymore. So they are classified as operative procedures. They're conducted in surgery, most of these, and they're carried out under aseptic conditions. They're not sterile, but they are under aseptic conditions. So if you're ever in surgery and you're doing a cystogram type of procedure, and the urologist is not wearing a mask, well, that's why. It's not sterile, but it is aseptic. It's as clean as we can get without being sterile. So cystography, we talked a little bit about that in class this morning, and that may be conducted in the ER after a trauma patient or after a patient's in a trauma. But there are other types of cystography as well. If the patient is suspected of having reflux, we might do some sort of cystography. Lower urinary tract infection would be another recurring lower urinary tract infections would be another. Um, and in both of those cases, what we're looking for is some sort of reflux. Scratch that, not the lower urinary tract, but the upper urinary tract would be for reflux. Bladder trauma, any kind of fistula. Fistula is an abnormal passageway between two things, or just abnormal passageway somewhere. So if the patient has, again, recurring urinary tract infections, that could be a cause of it. Urethral stricture, sometimes they have to actually stretch out the urethra. That's a painful procedure to watch. They put these large metal hooks up through the urethra, and it's painful to watch. Then bead chain urography is for stress incontinence, and most of the time we don't do that in the department anymore. A lot of your hospitals have their own designated urinary lab where they'll do stress incontinence studies. And most of the time now they just use a scope to look up into the patient's ureter or urethra and have the patient cough or sneeze, or somehow increase abdominal pressure to see if they have some sort of incontinence, stress incontinence. All right, so VCUG is avoiding cystourethrogram. We didn't talk about this this morning. With VCUG, what we've got in most cases are children who have two things going on. One is they probably have some sort of recurring urinary tract infection, kidney infections. And two is they're not growing as they should. So we call that failure to thrive. It usually occurs in young girls. And what we're going to do is we're going to have the patient in the radiology suite, and we're going to fill their bladder up, and then we're going to watch as they void their bladder and see if they've got some reflux. Now, think about that for just a minute. We have a young girl, probably older than 2, but probably not more than 8. So we got a young girl that we're going to perform this procedure on. And consider somebody who's maybe 5 years old, and consider where they've gotten in those 5 years. They've been told for their entire 5 years a number of different things. Don't let anybody see you. Cover yourself up. Don't let anybody see you down there. Don't let anybody touch you down there. And then every time they go to the bathroom, every time they go, empty their bladder in the bathroom, they get told what a big girl they are. So what we're going to have to do is, to see this exam, is have the patient on the table and catheterize the patient to fill their bladder up. So we're going to bring them into the x-ray department. We're going to have to see them, going to have to touch them, going to have to put a catheter inside them, going to have to fill the bladder up, and then we're going to pull the catheter out, and we're going to tell the patient to urinate on themselves. So a few things about this. One is that it requires a lot of patient care skills. If you're just not a kid person, you're going to have to suck it up and just, be patient with the little kid, because it's going to be very traumatic for the little kid. So you're going to have to be very patient. You're going to have to be patient with mom and dad, because as traumatic as it is for the kid, it's probably going to be just as bad for mom and dad. I don't think I've ever worked in a hospital where guys did these. It was always select females, and you're just going to have to be okay with that. Not everybody's built to take care of little kids. So understand that this is going to be very traumatic, and really pull out all of your patient care skills, because it's going to be really bad on the patient. If you can keep the parents out of the room during the procedure, everybody will be better off, but it's going to be bad on the parents as well. So we talked about the cystogram for trauma, so we won't go back into that. Sometimes your radiologist will want an apiaxial bladder. We talked about that this morning. So your positioning for that would just be as if you were shooting an image very similar to a coccyx. So you would center 2 inches above the upper border of the symphysis pubis, remembering that you really shouldn't palpate the patient's symphysis pubis, but if you go 2 inches below ASIS, it's going to put it at exactly the same place. Your central ray is going to be 10 to 15 degrees caudad, and what you should see then is more of the distal portion of the ureters. Sometimes your radiologist will want an upright post void on your IVPs, and we talked about that this morning. And sometimes they'll even want an upright apiaxial, so keep that in mind as well. So what we see that doesn't really look like an apiaxial because of the anterior pelvic bones, but where I got this image, it claimed this was apiaxial. So we're going to call it that. So you see these little things right here that kind of look like kidney stones. Those are what you call febulous. That's not on the test. It's just so that if you see those things, they're really nothing. What you've got there are calcified, at least minimally calcified suspensory ligaments, and you're looking straight onto them. So kind of like how you see the aortic arch real well, because it's coming out of the top of the heart and it's making that 90-degree turn and it looks nice and circular. That's kind of the same thing that you're seeing there. Those are not stones. So AP oblique bladder. This is not the oblique that includes the kidneys for the IVP, but if you're just looking for the bladder itself, 40 to 60 degree oblique. And what we're going to see there, positioning is really pretty much the same as the apiaxial. You can use ASIS as a marker or a landmark. And what we will see is more of the posterior portion of the bladder. And most of the time it's going to be bilateral oblique, so you're going to have an LPO and an RPO, not just a single oblique. Lateral bladder, never done this, but there it is. Male cystourethropography that they've got described here. The only time I've ever done a cystourethropography for patients was on a trauma situation, just looking for that the rupture of the bladder.